So it's an uncommon condition that accounts for 2% of the position in patients with atherosclerosis. Mostly atherosclerotic lesions we do for peripheral artery disease, we do for coronary artery disease, but 2% of the revascularizations done for atherosclerosis include intestinal ischemia and mesenteric revascularization. When the blood supply to the intestine is inadequate, the result because of these lesions should usually affect at least two of the three mesenteric arteries, so celiac, SMA, and IMA. Usually, a single vessel stenosis is quite well tolerated by patients because there are good collaterals. Gastroduodenal arteries there, IMA and the SMA have the arches of Buller and Reuland, which connect them. So often it is taken care of if there's single vessel stenosis. But when there are two vessels which are occluded, then the issue starts to crop up and the patient starts having pain. So patient may be symptomatic in is isolated lesion of the SMA also, but then the lesion should be slightly distal. It's not ostial, but mostly atherosclerotic lesions are ostial. Ostial lesions are well compensated, but say if there is a gastroduodenal artery and just distal to it, there is an SMA lesion. So the compensatory mechanism for SMA, which is the gastroduodenal artery, is also now joining proximal to the stenosis. So it really can't compensate downstream ischemia. In those cases, then we have to even treat a single vessel stenosis. Symptomatic CMI can be fatal because patient is not eating anything and we are going to malnutrition. Acute limb ischemia will lead to infarction of the intestine and death. So there we know that death is very common. But chronic mesenteric ischemia is a slow killer. It will make sure that the patient doesn't eat, they become ischemic, they become anorexic, they become malnourished, and finally, it can even lead to acute limb ischemia, acute intestinal ischemia as it progresses. But when it slowly goes up, it is because of these secondary issues that the patient starts to have problems and they can have multi-organ failure because of all the other issues. And treatment is mandatory if the patient is symptomatic because slowly it will lead to a major issue. And if patient is not eating, then he really can't survive for very long. We all know atherosclerosis is the most common cause of osteal stenosis of the visceral arteries. That includes the intestinal arteries as well. Other causes are rare. It's more common these beds. Say you have some vasculitis, arthritis. These things are more commonly affecting the visceral arteries in the periphery. So even in this, atherosclerosis is most common, but still good number of patients who non-atherosclerotic causes of stenosis, which includes, Takayasu disease, fibromuscular dysplasia, thromboangiitis obliterans, radiation-induced. People have had abdominal radiation that can lead, and the median arcuate ligament syndrome, where the median diaphragmatic arcuate ligament can cause stenosis of the celiac artery. So if that is there, but other vessels are fine, then it doesn't really cause. But if SMA, IMA is also affected, then celiac also has, arterial syndrome, then you are in trouble. Associated condition, multiple cardiovascular risk factors. Of course, see, atherosclerosis is the most common cause. So if you have multiple cardiovascular risk factors, they are only indirectly risk factors for other peripheral artery beds also. Atheromatous lesions in several territories, of course, coronary arteries, carotids, lower limb, if they are all there, then most likely uh, intestinal atherosclerosis doesn't happen, isolated. If you have atherosclerosis, you will have atherosclerosis all over the body, and as a result, the overall life expectancy of these patients is also small because they have coronary disease also, they have all other important issues also. The collateral pathway, as I told previously, that there is collateral circulation overall in the intestine. So normally doesn't happen too often that patient develop intestinal ischemia with just one solvent. So this is the celiac axis, this is the SMA, and this is the IMA. So SMA, IMA, celiac axis you see duodenal artery arcade. And then SMA and IMA, you have the arcs of Revlan and Bowler. So then you also have so communication from the internal iliac artery, which can fill in the IMA and it can backfill the SMA as well. So a couple of days back, only a patient whose primary filling was through the pelvic vessels. So this is also a very important thing we should know that through the pelvic, internal iliac also you have the IMA circulation, collateral circulation. This is one circulation we usually miss out. Also known as intestinal angina is the postprandial. Typical pain, patient eats sudden severe pain, which is known as intestinal angina. Result, they stop eating, they have fear of eating, many days, couple of days they eat anything, we have weight loss and of eating. Persistent nausea and intermittent diarrhea are less common, but they can be often. But nausea is very common, diarrhea is on and off, that shows that there is some intestinal ischemia. Ischemic gastropathy has high mortality, so you can have ischemic gastropathy also, but that's a slightly more severe form of ischemia, of chronic mesenteric ischemia. Patient can come with severe vomiting, postprandial heaviness because of gastroparesis. Bowel movement has reduced because of its less down. Gastroparesis, you can have slightly early ischemic changes in form of mucosal injury, gastric delayed gastric emptying, and if you do not get early treatment, then gastroparesis can set in. Very little food goes down, and their prognosis become extremely poor. Women with heavy smoking habits are often very significantly affected by gastroparesis. So that is one thing that you should know, that the risk of gastroparesis is higher in smokers, women who have intestinal angina. So imaging, you have balloon tonometry, you have fasting, and postprandial Doppler ultrasonography. So nowadays, the first thing that we do is fasting and postprandial Doppler ultrasonography. The rise in blood flow is not there. So fasting, the blood flow will be less, but as we eat something, postprandially intestinal flow should increase. So celiac acid, SMA, blood supply should increase. But if that's not increasing, say 1 hour, 1.5 hour post eating, then there is a problem that the intestinal circulation is not able to get enough blood when it requires that. MRA is possible when patient is not able to have contrast, or there is contrast induced nephropathy, or risk of allergy to iodinated contrast. But CTA is a much better option if the patient renal function is fine. Arteriography remains the step of every endovascular procedure. So finally, if you've seen CT, you feel that there is a possibility of treating it, and you have to do an angiography in an endovascular manner. So, as I said, CT angio is the most important pre-procedure imaging that you need to be able to plan imaging and be sure that one of the reasons that the patient symptoms are because of this. So this is CTA. You can see how you can see the vessels very nicely. This is a stenotic lesion. You have this is a post-stent occlusion, but it's the volume rendered images. You can very nicely see all the vessels when you do a CT angiography. This is MR. MR is slightly difficult to obtain. Patient has to cooperate. The images are not as good as CT angio. The sizing and everything is not as good as the contrast CT angiography. The anatomical understanding is much easier. You can get very thin sections nicely. So all those things, calcifications, all those things can be much better appreciated with uh, CT. In this Doppler, you have to see that you get a good peak that shows that the flow is fine. Also, you have to see the increase in blood flow in the postprandial period. There will be some increased blood flow to suggest that there is good compensation vessels during the postprandial phase. So the basic goal of treatment is to, of course, clinically ensure that the patient's symptoms and should be able to eat food well. His, pain should go away, which should result in correction of nutritional status, because if he's eating now better, he should be able to, gain some weight, be, better in all other forms, eat well, develop muscle mass, because they become extremely emaciated. They develop ulcers, they develop malnourishment related multiple issues. And of course, basically, this is doing well, his intestinal infarction will be prevented. So these are the goals of our treatment. So basically, patient comes to us. The first thing is having high suspicion. So knowing that such an entity exists, mesenteric ischemia can lead to this kind of postprandial pain. Patient eats after few minutes, few hours, so patient has pain. Usually 1 hour later, 1.5 hour later, the pain increases and goes up till 3 to 4 hours, and is not eating, significant weight loss, there is fear of eating. So all those things are there. Then not necessarily everything is ulcer disease, or not everything is a mucosal gastrointestinal disease. You need to think beyond. If the endoscopies are normal, if everything else is fine, you need to try and get a CT scan done and do an arteriogram nicely, so that the arteries can be well seen. So if you have at least two vessel involvement, say between celiac, SMA, and IMA, if two of the vessels are significantly involved in the imaging, then you should think about this etiology. Also, this is the diagnosis of exclusion. So, of course, everything else we primarily try to exclude before we can say that these issues are primarily because of mesenteric arterial ischemia. Prophylactic revascularization can be done if even when patient is, not having those many symptoms, but if you see those stenosis in the imaging, maybe, patient is anyway undergoing some other procedure, some aortic procedure where aortic aneurysm they were treating, and, alongside they treated this also. Or patient is planning to undergo an abdominal surgery that might compromise the collateral network. So even though there is stenosis, but right now, patient is not symptomatic because of collateral, but as you do surgical abdominal major surgery, there can be breaking of the collaterals, and then it could be a problem. So you can pre-treat the situation in those cases. But otherwise, even if you see some stenosis in the CT in a patient who's otherwise being evaluated for pain abdomen, then and if it gets treated with that, or patient had it for some other reason, some renal urography was getting done and it got picked up in that. So then those times we just wait, we do not and have any treatment. So percutaneous revascularization of CMI was first reported in 1980, and from there on, this procedure has taken up as a primary intervention before surgery, because it's low morbidity, low mortality, very easy for the patient. So the technical success rates were quite high, and the symptomatic improvement was very high, and the risks, associated with the condition were much, much lower. Symptomatic relief was there in most patients, but 20 patients experienced no symptomatic relief also. So the thing is that even if we try do every exclusion possible, there is sometimes we can't pick up the real cause. So there is chance 1 out of 5 may not get the kind of symptomatic relief that they are looking at. Sometimes those changes become chronic, the bowel changes become chronic. Sometimes the cause is something else, which then requires further understanding. The symptoms were likely because of some other cause than bowel ischemia. So that is possible. Even after, doing your best, sometimes they are functional causes, psychiatric causes. But if you find these situation, then you have to kind of treat it. Can't, just keep waiting and think of it as functional. So those repeated after, restenosis rates are very similar to, those reported after renal artery angioplasty and stenting. Primary patency is around 75-80%, and assisted patency, withstand with, reballooning. Then that can lead up to around 100% rate of patency. You can always reopen it if you require stenting. Then if you stent it nicely and patient keep on, dual antiplatelets, then the rates can be extremely, extremely high. Just plain balloon angioplasty has lower success rates, but lower restenosis also. Because if you get good result with just plain balloon, then you can leave it at plain balloon. But mostly you require stenting. But the problem with stenting is that instant restenosis rates are higher than just post ballooning. Somebody is asking me what is percutaneous revascularization and how it is done. So we will have cases for that's all what we're discussing. First thing we need to understand is why we are doing. Do not think yourself as just somebody who's to do a procedure. This is the most idiotic thing somebody can think about as being IR. That is the reason IR as a field doesn't grow up because most colleges the consultants don't want to take any responsibility. They just want केस आएगा हम करेंगे वापस चला जाएगा. हमें नहीं सोचना है कि why is it required, who it should be given, what is its future, if you do the procedure, what are the chances that the patient will improve, because all these questions the patient will ask you. But if you're not interested in talking to the patient, not taking him up as a primary physician, then of course these things don't really care, but if matter to you. But if you do not do all of that, there will be a day where all these procedures will be done by the primary physician who is handling the patient. They will learn, they will kind of get whatever they need to do. So you need to understand that if you want to do a procedure, you have to first learn what is the clinical part associated with it, how the patient will present, how you'll work up the patient, what is the investigation that you need, what are the symptoms that are more specific, then how do you tell the patient that these are your options, how do you image the patient, and then you have to tell them also if you do this procedure, the first question everybody asks you, you've been in clinical practices, सर ये पक्का ठीक हो जाएगा, हमेशा के लिए ठीक हो जाएगा. So these are the questions you need to be able to answer in proper terms, because otherwise these can be a big problem later. You tell somebody हाँ हम procedure करेंगे, it will be fine, doesn't work out if you've not told them that 15 to 20% of the patients may still not get any relief, but usually they are so badly affected that most patients become ready to get the procedure done. But that initial counseling is very important. So those are important things that you should learn. We will percutaneous revascularize in what? What do you mean? You mean percutaneous procedure which you will do revascular. Percutaneous angioplasty, what does it mean? It means you just go and angioplasty the artery. So that part is now where we'll discuss cases further. But this is actually more important than the procedure, because procedure with time, when you do a fellowship, when you learn the things, you will be fine. But the problem comes with picking the right patient and trying to do the procedure in the right patient. So this is the simple angioplasty versus simple angioplasty with stenting and primary stenting. So if you do angioplasty, the immediate success rate is 83, 90, 95%. But the long term success rates, they will slowly start coming down for plain angioplasty. Restenosis rate almost, similar. Restenosis rate, as I told you, slightly higher in primary stenting, but usually, the initial people who do get a result with just angioplasty is lower. So mostly you will have to do stenting in these patients, because the primary technical success rate with just angioplasty is slightly lower. With stenting, you're nearly 95-100%, whereas here it is 80 to 83%. So that 10-15% patients you will have to definitely do stenting. So you know that already 10-15% patients may not get good result with this. So you go towards end up going towards primary stenting. But primary stenting, there is one problem, that restenosis rate is slightly higher. When you just balloon, and if the balloon does well, the chances it goes back is lesser. So if you compare these, percutaneous procedures, somebody may say, ki, okay, there is a chance that this may not work, surgery might work 100% of the time, maybe. But the problem with that is long-term patency rate is pretty high with this. First thing is, it's not like you have poor success rate with percutaneous route, so that is good. Even 9, 10 years rates are very high, 70, 80%. 80% of them have a persistent open vessel. The overall survival rate is just 60%, because 5 years later patient usually have so many other comorbidities that they do not make the entire time. It's not necessarily that they die because of intestinal ischemia, but they have cardiac issues, PAD. So when you see those things together, you'll realize that a person will survive 60% of the time, but the patency rates are 80, 85%. That's very good patency rate. You can always feel, you almost feel that the patient, lifetime might be okay. Just with this procedure, he may not need a second procedure later. But these patients with so many comorbidities, if you try to do conventional surgery, then they have very high perioperative risk. If you try to do a vascular anastomosis, reattach the SMA to some other place in the aorta, or the IMA to some other place in the aorta, then you have significant operative risk. With conventional surgery, post-operative mortality is around 0 to 17, of course. So 17 is pretty high number, 0 is less. That depends on the patient selection, that depends on the uh, hospital expertise, the doctor's expertise, how many surgeries they have been doing regarding this. But the morbidity is pretty high. It's like minimum 15 to 45% patients who have significant post-operative morbidity, maybe long-term stay, infections, wound healing, so many other problems that the patient develops because of a open surgery. Now, surgery versus endovascular, if you see, the safety is much higher. Mortality is definitely lower. Mortality in endovascular more, because if you can't open the vessel, there's end up being, acute ischemia. If you try to do too much manipulation while opening, suddenly the artery thromboses again. So that can stimulate or cause acute ischemia. But per se, endovascular intervention, mortality is very low, and morbidity is also pretty low as compared to surgical procedure. So this is where, how we do the procedure. You have a aorta, you see a stenotic lesion. So you see here, this is the stenotic lesion, this is the aorta. So we bring a catheter. This sheath is there. With the sheath, we take a run. We try to see this part, we try to go into it, take a wire, cross the stenosis, take a catheter, wire goes in, then you get the sheath down, try to cross with the catheter, bring a balloon. So now you have a balloon in the location of the stenosis, then you pull out the sheath. So you actually, because sometimes what happens, the balloon or the balloon mounted stents may not cross the stenotic lesion. So first we try to get a sheath into the stenotic lesion, then pass the balloon or the balloon mounted stent, and then pull back the sheath, so that the sheath and the balloon do not get damaged while we are crossing. And then you cause inflation and you put a stent or just an angioplasty, depending what you think is required.